Good morning, online students. Or to me, it's good morning. It's about 6:38 in the morning, so it may be afternoon to you or evening, whatever it is, good to you. I'm going to be recording my last thing, which is going to be over the pituitary gland. As far as the adrenal glands, the thyroid, and the parathyroid, I have posted fast fact sheets in the content module. Week 2, so please read over those. I have set up a little discussion area in the discussion board for question and answer session. So if you have any problems and you need to put something in there, I'll be glad to get back with you, and I'll be checking that daily. Thank you very much. Okay, and we'll get started with this. It may take a little bit. All right, the endocrine system and endocrine disorders, the other ones. This is the fun stuff. All right, it says, do you remember? The hypothalamus is very, very important. Even though we say the pituitary is the master gland, the hypothalamus really has a lot going on as well. If you look at this very first row, and if you don't remember what all these mean, there is a table on page 1359 in your book. So if you don't have your book available, MedSurge book and Pete's book, you want to get them out so that you can follow along with me. But what it means, if you see an RH, it's releasing hormones, IH is inhibiting hormones. So this would be growth hormone inhibiting hormone, growth hormone releasing hormone. So you can see here prolactin, your gonads, your thyroid, your corticosteroids. But this first line is everything that's within control of the hypothalamus, everything here. This second line is hormones that are secreted from the anterior pituitary. So this is the anterior pituitary, what's secreted from it. And this last line is actually the target organs, okay? You can see some of these have target organs and some of these do not have target organs, okay? Now, the first four here, ACTH, FSH, LH, and TSH, are all called tropic hormones, T-R-O-P-I-C, tropic hormones. The other three are called non-tropic hormones. That would be your growth hormone, your MSH, and your PRL, or prolactin. Now, what that means, tropic means they travel through the blood and exert their action only on target tissues. So when ACTH is released, it is headed straight to the adrenals, and that's it. When FSH and LH is released, it's headed straight to the ovaries and testes. When TSH is released, it's headed to the thyroid. They have lock and key system mechanisms on the tissues in which they act on that actual gland. Non-tropic over here means they're stored in the nerve tracts of the pituitary, and they're just simply released when they're needed into the bloodstream. Now, what you need to remember about these is that MSH and ACTH have a relationship. And MSH, well, all I want you to remember about MSH is that it's responsible for pigmentation. It's responsible for pigmentation. And when MSH levels are up, ACTH levels are up. When ACTH levels are down, MSH levels are down. So they go in the same direction. All right, the pituitary gland, aka the master gland. It has three parts, and on page 1361 in your book has a good visual for that. Shows you the hypothalamus, shows you the hypophyseal stalk, shows you the posterior pituitary and the anterior pituitary. If you look there, the three parts, the anterior, the intermediate, and the posterior. The hypothalamic pituitary blood system carries hormones from the hypothalamus to the pituitary, so that would be going from the first line to the second line to the pituitary. Located between the hypothalamus and the pituitary gland is what we call the hypothalamic hypophyseal portal system, or the stalk, and that's what carries those hormones between the two systems. If you'll remember, when we talk about the body, there's positive and negative feedback systems. Page 1360 gives you an example of both of those, a simple versus a complex feedback system. So I want you just to read over that. It's pretty self-explanatory. And if you have any questions, please let me know. So there's 3 potential problems we can have going on here. Something can go wrong with the hypothalamus and we're going to have trouble. Something can go wrong with the pituitary and we're going to have trouble. Or something can go wrong with those target glands on that 3rd line and we can have trouble. So lots of potential problems when we talk about the endocrine system. So in a nutshell, the nervous system actually receives and reacts to various stimuli that's transmitted to the hypothalamus. Then the hypothalamus responds by stimulating the production and release of releasing or inhibiting factors that are transported to the pituitary. Then the pituitary, the factors either stimulate or inhibit the release of hormones that's controlled by the secretion of hormones from a target organ or to tissues. So that's what happens in a nutshell. Now, diagnostic tests are on page 1369, if you'll turn over there with me. On page 1369, the very first thing it talks about is stimulation and suppression tests. And these are given when you suspect either underactivity or overactivity of a gland. So if you'll look on page 1369, it talks about stimulation and suppression test. It says, for a patient who might have an underactive endocrine gland, a stimulus may be provided to determine whether the gland is capable of a normal hormonal production. This is called stimulation testing. Measured amounts of the selected hormone are given to stimulate the target organ to maximize production. Then hormone levels are measured and compared with what the expected norm values should be. Failure of the hormone level to rise with stimulation indicates hypofunction. For example, insulin injection should stimulate increased release of growth hormone and ACTH or cortisol from the normal anterior pituitary gland. If you'll remember, I told you earlier that growth hormone and cortisol are counter-regulatory hormones to insulin. So if you give insulin and you're bottoming someone's sugar out, those 2 levels should rise normally. When insulin injection does not result in an increased release of these hormones, then we know there's a problem with the pituitary gland likely, especially hypofunction. Now with the suppression test, these are used when hormone levels are high or in the upper range of normal. Failure of suppression of the hormone production during testing indicates hyperfunction. For example, when a bolus of glucose is given orally or intravenously, normally the anterior pituitary responds by suppressing the release of growth hormone, because now we've got our levels up. A hyperfunction anterior pituitary gland will fail to suppress growth hormone release when blood glucose levels are elevated rapidly. So if you don't understand that, be sure you get with me, because we're going to be talking about a lot of stimulation and suppression tests. They can do assays, which measures the level of a specific hormone in the blood or other body tissue. So it's just to measure hormones. As far as the urine test, if you look on page 1369, there's chart 64-3, best practice for patient safety and quality care endocrine testing. If you look down there, it says for blood test and for urine test. Be sure you read over for urine test and you understand that. Okay, you will see that again. Tests for glucose can be anything from hemoglobin A1Cs to blood glucose levels, etc., etc., and we've already talked about those. X-rays, MRIs are also done especially to test for tumors and to check for tumors, because that's a big culprit, especially in your hyperfunctioning disorders. Alrighty then. Let's start out with the pituitary disorders. This is chapter 65 in your MedSurg book and 29 in your PEDS book. Anterior pituitary. The anterior pituitary is where we're going to start. Remember, there's 2 parts, anterior and posterior. The hormones in the anterior pituitary are ACTH, TSH, LH, FSH, growth hormone, prolactin, and MSH. Remember, the only thing I want you to remember about MSH is responsible for pigmentation and that it has a direct relationship with ACTH. When it's up, it's up. When it's down, it's down. Now, the posterior pituitary has 2 hormones, oxytocin and vasopressin. So what affects the release of pituitary hormones? Well, lots of things can affect the release. Drugs, the diet you're on, lifestyle changes, pathological conditions. So it's not just one thing. You have to search for the etiology. Which of the anterior hormones are tropic? Tropic means they stimulate other endocrine glands. Remember, there were 4 of them. So if your mind quickly went to ACTH, TSH, LH, and FSH, you're correct. What's the causes of disorder of the pituitary gland? Well, disorders are either caused by either hypofunctioning or hyperfunctioning of hormones. Almost always, if it is a hyperfunctioning problem, it is because of tumors. If it's a hypofunctioning problem, though, it can be from several different things. Anything from a pituitary gland infarct to surgical involvement to genetic disorders to tumor tissue. So on our adventure, we're going to discuss disorders of the non-tropic hormones first. And I know you remember these. There were only 2 of those. GH, growth hormone, number 1, and number 2, prolactin, PRL. Now remember, there was a third one over there, but it was MSH. And I've already told you, you only have to remember 2 things about MSH. It's responsible for pigmentation, and it has a direct relationship with ACTH. So first stop will be the growth hormone, hypo and hyperfunction secretions of the growth hormone. Now, let's review the functions of growth hormone. This is a counter-regulatory hormone, which means it's counter-regulatory against insulin, therefore it increases glucose levels. So we've got that one, increases glucose levels. But it also increases protein synthesis, breakdown of fatty acids, affects metabolism, causes cells to grow, stimulates the liver to produce somatidins. Now, what are those? Well, these enhance the growth activities in cells and tissues, and they're responsible for bone and cartilage growth and maintenance. So they're very important in bone and cartilage growth and maintenance. So let's talk about hypopituitarism. Hypopituitarism in general means that there is a decrease in one or more hormones in the pituitary. So it's kind of general. But we're going to focus on growth hormone deficiency. And deficient secretion of growth hormone in children results in a condition known as hypopituitarism, dwarfism. And it affects about 1 in 10,000 children. Now in adults, this is going to be hard to diagnose because the growth plates have already closed. So then we're going to be looking at the length of the bone not being affected. Instead, because the somatidins decrease action, there's actually an increase in bone destructive activity, leading to very thin and fragile bone. So they end up with a lot of osteoporosis. Now, this is usually diagnosed earlier in males. Why do you think dwarfism is usually diagnosed earlier in males? Well, part of that's because the evaluation of short stature in males is of more concern than it would be in a female because of our societal biases and beliefs. So part of it is just because of our society. Causes, well, anything from heredity. It can be acquired through trauma, drugs, and tumor. But over half of the causes in children is actually idiopathic, meaning we don't have a clue. It can be from pituitary infarction. Something happens, particularly in the postpartum period. We have what's called postpartum hemorrhage or Sheehan syndrome. And Sheehan syndrome is when the pituitary gland normally enlarges during pregnancy. And when hypotension results from hemorrhage, ischemia, necrosis of that gland occurs. It affects it. So this condition develops immediately after delivery, although some cases do occur later. This is one of those things you want to keep in the back of your mind that can happen during the postpartum period. Now, there's also something called a psychosocial dwarfism. Yes, this does exist, psychosocial dwarfism. This is a syndrome of emotional deprivation that suppresses the release of growth hormone. When removed from the environment and they're put in a nurturing environment, the syndrome is reversed. So it's just because of the environment that they're in at that time that they fail to grow. Manifestations. Well, the main thing you're going to see is short stature. Height is retarded more than weight. Very immature in their appearance. Dental eruption is delayed. Their hair is thin with poor nail growth. High-pitched voice. Sexual development may be delayed but normal. And the development of hypoglycemia. Now, the child will usually obtain an acceptable height with proper interventions and with compliance with medical treatment plans. Why the development of hypoglycemia? Well, in the infant, this might be actually your first sign of dwarfism because growth hormone, remember, is a counter-regulatory hormone that's responsible for helping maintain normal blood sugar levels. If you're starting to see a lot of signs and symptoms of hypoglycemia and diabetes has been ruled out, you may want to look into growth hormone deficiency. Diagnostic evaluation. Well, growth patterns that deviate from the normal growth rate is a red flag. They keep coming in and they're staying below the 5th percentile on that growth chart. Red flag, red flag. X-rays of the hands and wrists will actually be done to check for actual skeletal age and see if it matches their chronological age. Definite diagnosis is based on growth hormones levels that are stimulated pharmacologically with agents. So we are going to do, it looks like a stimulation test because we have a hypofunctioning organ. Growth hormone levels less than 10 nanograms per milliliter would be considered positive. So it sounds like we have come across our first stimulation test. So what agents do they use in the stimulation test? Insulin is the main one, but they can use like L-DOPA, propranolol, clonidine. Those also help lower the blood sugar level. But insulin, again, is the most common agent used for the stimulation test. Insulin is the most common used for the stimulation test. So what they're going to do, they're going to give insulin. And when they give insulin, of course, the blood sugar levels start going down. With the blood sugar levels starting to go down, we would expect the growth hormone levels to go up. But if something is actually wrong, then they will not go up. They will continue to be down because it can't react. It's broke. All right, so what would you expect to happen after giving the insulin? What would you expect to happen after giving the insulin? The levels would go down and growth hormone levels would go up. So what are you going to watch for during this test? Hypoglycemia. You have to monitor them very, very carefully because there's some of your other counter-regulatory hormones or cortisol and some of the others may step up and help as well, but it's still a very sticky situation with growth hormone not on board to help. Therapeutic management of growth hormone. Of course, we're going to treat the cause. Most, though, if you'll remember, over half were unknown etiologies or idiopathic. Definite treatment is replacement of the growth hormone. The drug of choice is somatotropin or somatotropin, which has a success rate of 80 to 90% of the time. And there are some newer drugs. Why is biosynthetic growth hormone given instead of the natural form? Well, it's because of something called CJD, Creutzfeldt-Jakob disease. And this also has affected people, and they cannot They cannot donate blood as well if they have had this. This is a rare neurodegenerative disease found in human cadavers. It's a rare neurodegenerative disease found in human cadavers. It's very similar to mad cow disease. So blood banks do not accept donations from formal recipients of growth hormone that was made biosynthetically because of the inability to test for the infection of CJD. Okay. Now, how is somatotropin given? It's given sub-Q, and you need to alternate sites. It's given at bedtime so that it most closely approximates the release of growth hormone. And at about 9 years of age, they will start to give their own shots with help. They should start being able to give their own shots with help. Nursing considerations. Need to remember these. The parent should be told the child will grow most during the first year, about 8 to 10 centimeters, then it will decrease. Parents should be encouraged to interact with the child according to their age, not their size. Hormonal replacement support in preparation is expensive, up to about $35,000 a year. Then the child itself may need emotional support and follow-up care. Now, if you'll remember, 1 inch is equal to 2.5 centimeters. So we're talking about 4 inches total in the first year. So about 4 inches total. Then it will decrease to only 1 to 2 inches thereafter. 1 to 2 inches thereafter. Now, these kids may be teased and called names like short and shrimp and midget and picked last for the sport team. So they do need this emotional support. Alrighty. Questions is, when does the therapy stop and why? When do you think the therapy would stop and why? Well, it should be the period right before the epithelial plates or the growth plates closes, or appropriate growth height has been achieved, either one. The period right before the epithelial or growth plate closes or appropriate growth height has been achieved. That's about 14 to 15 in girls and 15 to 16 in boys. Because if you kept giving it after that time, then you're going the opposite direction. You're going to have too much, and acromegaly could result. So 14 to 15 in girls, 14 to 15 in girls, 15 to 16 in boys, and it could result in acromegaly if you don't stop. So what are our cultural beliefs in the United States about stature? Well, we actually had a song out years and years ago called "Short People Have No Reason to Live." I don't know if y'all remember that, probably way before some of your times. Tallness is associated with wealth, strength, and power in our society. So there is something about short stature. All right, let's look at just the opposite. Hyperpituitarism, growth hormone excess. One example is oversecretion of growth hormone. What is the main cause? Dun, 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 dun. You should have already know this one. Tumors. Remember, hyperfunctioning tumors is the main cause. In the child, you get gigantism, and in the adult, you get acromegaly. Okay. What's the manifestations of the two? Well, gigantism in the child results in abnormal increases in your long bone up to 8 feet tall. Height and weight exceeds 3 standard deviations above the mean. Organ enlargement is a huge thing because that is what causes a lot of death. Hypertension, heart failure, and delayed fontanelle closure, and again, death can occur. Acromegaly in the adult, you will see bones broadening, increase in thickness and width. You'll see enlargement of soft tissue, facial changes. You'll see changes in ring or shoe sizes, and those don't go back once this is taken care of. Headache, visual problems, sinus congestion, deepened voice, kyphosis, and sexual dysfunctioning. Now, if you look on page 1375 with me, you'll see the progression of acromegaly in a child as she was growing up. You can see how her bones are broadening and increasing in thickness and in width. She's got facial changes, particularly the enlargement of her soft tissues. So you can see there that it does follow a distinct pattern. All right, so what makes the difference in the signs and symptoms you see in the child versus the adult? Again, growth plate closure. Growth plate closure makes the difference in what you see. Okay. Now, in this syndrome, girls are usually evaluated more than boys. Just the opposite. Why? Because tallness of boys is seen as an advantage, particularly in sports. Okay. Diagnostic evaluation, history of excessive growth in childhood, increased levels of growth hormone, x-rays and CT scans, MRIs, visual acuity test. They will do some x-rays to check for enlargement of the sinuses. And in this case, now we're going to start a suppression test. And we're going to do that by doing what we call a glucose load. If you're looking at the history of excessive growth chart in here, now it's going to be the opposite. Instead of them consistently falling in the 5th percentile, now they're going to be consistently above the 95th percentile. Increased level of growth hormones, they can be greater than 50 nanograms per milliliter, greater than 50 nanograms per milliliter. Again, why are they doing the x-rays, the CTs, and MRs? To rule out the tumors. Why are they doing visual acuity tests? The tumor may be actually putting pressure on the optic nerve and they're having visual problems. The tumor may be putting pressure on the optic nerve and they're having visual problems. Enlargement of the sinuses causes a broadening of the bones and causes other problems. And then we have the suppression test. Now what they will do with this one is do a glucose load. And a glucose load will be performed and when it's performed, growth hormone will be suppressed in the glucose tolerance test. So what they will do is they will give 100 grams of oral glucose, okay? And oral glucose would increase the blood sugar. If it increases the blood sugar, then growth hormone levels should be suppressed. Then they measure growth hormone levels in about 120 minutes later. Growth hormone levels should go below 5 nanograms per milliliter. They should drop. If not, then the test is positive, okay? If not, the test is positive. Now, in children, they can be up to 10 nanograms per milliliter or lower they should drop to. So in the adult, they should go to 5 or lower. In the child, they should drop to 10 or lower. But again, what you're going to see is that level is not affected because something's wrong with the gland itself. It's hyperfunctioning and the suppression test did not help. Therapeutic management, the goal is to return the hormone levels to normal or near normal. They will do surgery, that is the treatment of choice. Radiation is not very useful. Radioactive implants have been tried, and then pharmacologically, this is the main thing they try first. Dopamine antagonists, such as your Parladel, is given particularly. And with children, high doses of sex steroids can be given to close the epithelial plate early. Medications work by decreasing the PRL and the growth hormone levels. That's one of the things that these two meds do on the side. These are may be used prior to surgery to get the levels down. They stimulate dopamine receptors in the brain, and then that's going to inhibit the release of a lot of your pituitary hormones. And particularly, they work on growth hormone and PRL. So they indirectly cause a decrease also in the size of tumors. So there's lots of reasons we start with the medication route first. Okay. Now, of all the ages, again, adolescents are usually affected the most, and that's partly because of what they are going through. Now, they can have surgery. If you look on page 1376 in your med-surg book, they can have what's called, if the medications don't help, a transperineal hypothectomy. Now, they do a complete or partial removal of the pituitary gland. They're going to have lots of pre-op teaching. You're going to be cleaning the nasal passages before surgery, antibiotic sprays to make sure they don't have any infection, to prevent infection during surgery, getting baseline vitals and weight, preparing them that they're going to have nasal packing for 2 to 3 days, and any potential post-op complications that might occur. So if you look in your book on 1376, it talks about the actual operation procedure. And what they're going to go in there and do, if you're looking on that page, is a microscopic surgery that's performed when they're under general anesthesia and in a semi-sitting position. And the surgeon's going to make an incision just above the upper lip. And they're going to go in and reach the pituitary gland through the sphenoidal sinus. And after the gland is actually removed, a muscle graft is going to be taken, often from the thigh. So they'll go in and they're going to have a dressing that's going to be on their thigh because they're going to take a muscle graft. And they're going to take that to support the area and prevent leakage of cerebral spinal fluid. Then they're going to have nasal packing that's inserted after the incision is closed. A mustache dressing is then going to be applied. And if the tumor can't be reached by this approach, then a craniotomy has to be performed. But this is the way that they try to begin with. The bad thing is when you take the pituitary out, you affect other hormones, because remember the pituitary was over several hormones in that second line. So it will need, they'll need supplemental therapy of all the hormones in the pituitary for life if you have to take and do a complete removal of the pituitary gland. And you can read up more on the operation procedure there on page 1376. Now, preoperative teaching again, we're going to continue to teach them not to brush their teeth, to cough or sneeze. Of course, you can help it if you sneeze. Don't try to blow your nose, bend forward, anything after surgery, because all of these activities could open that muscle graft back up, could increase intracranial pressure and delay healing of the incision. So all of these activities could open the muscle graft, increase intracranial pressure, and delay the healing of the incision. Nasal and mucous membrane swabs prior to surgery. And again, the mustache dressing or the drip pad will be placed under the nose for 2 to 3 days. You want to watch for two main complications: DI, diabetes insipidus, or ICP, increased intracranial pressure. DI, particularly because the decreased production of ADH. They can urinate as much as 15 liters in a day. So if you've got a patient who's had a transperineal hypothectomy who comes back and starts urinating and urinating and urinating and won't quit, they probably have developed DI because you affected the hormones, particularly ADH. So measuring I's and O's, specific gravity, and daily weights are imperative post-operatively. Increased intracranial pressure again can occur, so you want to watch them for headache, nausea, vomiting, visual changes, restlessness, postnasal drips. Keep the head slightly elevated after surgery of no more than 30 degrees, so about 30 degrees. So if they're complaining, they're coming back, let's say it's post-op day 1, they're thirsty, they're voiding, you need to call the doctor because they have probably developed DI. They come back after surgery, they're having extreme headaches, nausea, vomiting, visual changes, complaining of a postnasal drip, you want to call the doctor. They probably developed ICP. All right, so you want to monitor the mustache dressing for drainage. Clear yellow tinged fluids should be checked for glucose always, because cerebral spinal fluid leakage could be occurring. Look for what we call haloing to occur, okay? And that's like a light yellow color at the edge of the clear drainage. It's like a halo sign. And that usually indicates cerebral spinal fluid leakage. All right, if they continue to have the leak and headaches, then they may have to go in and actually fix that. And then usually, a lot of times it'll just resolve on its own with complete bed rest. But if they don't, then they will go in and fix that. Nuchal rigidity, if they start complaining of a stiff neck, you want to make sure you notify the physician because they also can develop meningitis with this surgery. Okay. Other considerations. Well, you want to encourage oral fluids. Let them know they'll have a temporary loss of smell. Providing oxygen and humidity is needed. And providing mouth care. Hormonal replacement therapy is needed. Head a bed up. Mild analgesics for a headache. And to avoid increased intracranial pressure, you want to teach them not to bend over at the waist. That's hilarious. It should be W-A-I-S-T, at the waist. Not to bear down, cough, or lie flat. That's your funny for the day. On page 1377, there is best practice for a patient after hypothectomy that you'll need to read over. And it's basically what we've talked about. And then there is home care assessment, the patient who's undergone a transperineal hypothectomy. So you want to make sure you read over those two charts on 1377. Watch the child with excessive growth rates as a nursing consideration. They're starting to come in and it's 95th, 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 and you need to be thinking gigantism. Emotional support. Watch for the adult who complains of changes in shoe, hat, and ring size, changes in appearance, and we've seen that in that one picture. There's also an Acromegaly Network Association that's a huge support group for adults with acromegaly. Now, prolactin disorders is another adventure. When is it normal to have an increase in prolactin? After pregnancy. One normally does not see hyposecretions relating to delayed puberty. If so, it's usually a secondary cause like gymnastics. We know gymnasts who put their body through that kind of training day after day after day have delayed puberty. But one usually will see hypersecretions. And what causes hypersecretions? Tumors. Hyperprolactinemia, or PRL is what we're talking about, is when we have secreting tumors. The most common cause of this is pituitary adenomas. And increased prolactin level causes a lot of things. It causes a loss of secondary sexual characteristics, decreased gonadotropins, your LH and your FSH levels, causes lactation, increased body fat, increased serum prolactin levels, and gynecomastia, or breast development in men. And these are very small tumors causing all this problem. Usually they're considered microtumors and the size is less than a centimeter. Now, diagnostic levels, if it's greater than 200 nanograms per milliliter, then it's considered positive, especially if you have some of these symptoms. Just for a reference level, 20 is normal for prolactin. 20 nanograms per milliliter is normal, and you'll see it as high as 200. Manifestations, you're going to see breast changes, increased milk production, amenorrhea, headache, decreased libido, impotence in the male. Visual disturbances, decreased visual fields because of the pressure on the tumor, and lethargy. Now, what is the reason for these first 5 signs and symptoms? Well, these first 5 signs and symptoms is prolactin excess has a negative feedback system to the pituitary gland. So if you didn't read about feedback systems, you need to go back and read. So what that's going to do is suppress gonadal functioning. Now, Parladel, again, this decreases PRL production. We talked about that being one of the things it did. So we're going to give doses starting at 1.25 to 2.5 and increase it to 5 to 7.5. And you don't have to know that for test purpose, just know they increase it. It is given with food. And if signs of tumor enlargement continue to occur, then you're going to have to notify the MD. Because if the medication, again, does not work, then we're headed back for a transperineal hypothesectomy that we talked about earlier. All right. Another condition you need to be aware of is called precocious puberty. And this is on page 979 in your PEDS book. And this is an abnormal early appearance of secondary sex characteristics. Precocious puberty means ripe before your time. Ripe before your time. R-I-P-E, ripe. Causes, unfortunately, 80 to 90% are idiopathic, meaning we have no idea. There also can be caused from a pituitary tumor, but that's quite rare. The 2 types, you have true or complete and incomplete. With true or complete, also known as central precocious puberty, the gonadotropic dependent prematurely activates the hypothalamic pituitary gonadal axis. And this is what's responsible for those increased hormones during puberty. So there's a premature activation of it. With incomplete precocious puberty or precocious pseudopuberty, the gonadotropin independent usually is secondary to tumors. Remember, this is the type that's quite rare, so most of the time you're going to see true or complete. Diagnostic levels would be increased levels of LH, FSH, GN releasing, and that's the gonadotropic releasing hormones, and they look at bone age. They will show early manifestations of sexual development. Boys before 9, girls before 8, as young as 4. In boys, secondary sexual development before 9. In girls, breast before 7, 7.5. Pubic hair before 8, 8.5. And menses before 9. Now, they are producing mature sperm and ova. Kind of scary. The only permanent complication of precocious puberty is short stature. Why would short stature be a permanent complication of precocious puberty? Well, if you think about it, excessive sex hormones, the body thinks it's in puberty or going through puberty, so it prematurely closes that growth plate. So if it prematurely closes that growth plate, then it affects with the overall height of the child. If it's incomplete, we're going to treat the cause, remove the tumor. If it's true or complete, then we're going to give medications. In this case, we're giving daily, sub-Q, or monthly IM injections of Lupron. That is the most common. We can also give some intranasally spray, but the most common one is the Lupron. When would treatment be discontinued and why? Well, it should be discontinued about the same time puberty would occur, around 11 in girls, 12 in boys, because that regulates pituitary secretions of LH and FSH that stimulate the gonads. So about the time of puberty is when it should be decreased. Now, these children also need emotional support. Anytime a child or adult has an alteration in their sex hormones, you need emotional support. The R needs to help them cope with the changes in their secondary sex characteristics. But they still need to dress appropriately. They still need to participate in activities that are age appropriate, even though they appear to look older than what they are. They will have increase in hormone levels, so an increase in sexual drives as well. You need to remember that. Teach them about injections, the Lupron injections, and the cost is going to run around $10,000 plus a year. The posterior pituitary. No invention would be complete without a stop at the posterior pituitary. And if you'll remember, the posterior pituitary does not produce hormones. It stores and releases ADH and oxytocin produced by the hypothalamus. ADH and oxytocin. ADH. We know that ADH acts on the kidney tubules to reabsorb water, thereby regulating fluid volume. Oxytocin stimulates urine contractions and milk ejection reflex. So those are their functions. So let's look at hypo and hypersecretions of ADH. Hyposecretions of ADH results in a condition known as DI, diabetes insipidus. Now this is not to be confused with diabetes. It has nothing to do with diabetes mellitus. Diabetes insipidus. And what does this produce? It produces a state of uncontrolled diuresis. Hypersecretions of ADH results in a condition known as SIADH. SIADH. And that stands for Syndrome of Inappropriate Antidiuretic Hormone. Syndrome of Inappropriate Antidiuretic Hormone. And it results in excessive water conservation. It results in excessive water conservation. This is in your Pete's book on 890 and in your MedSearch book on page 1378. There's 3 types of diabetes insipidus. There's neurogenic, nephrogenic, and psychogenic. Neurogenic is the most common. That means there's an actual problem with either the hypothalamus, I can't even get it out right now, or the pituitary. Nephrogenic is an inherited disorder. There's something wrong with the renal tubules. They're defective. There's something wrong with the renal tubules and they're defective, their cells. How do you treat nephrogenic? You give them salt and protein restrictions and diuretics. Now, psychogenic is those who are compulsive water drinkers, and they actually have to have psychological help. This is quite rare, but it does exist. So the main one we're going to be talking about is neurogenic. Patho. Normally, thirst is regulated by ADH. Release. The release of ADH stimulates thirst. ADH facilitates the concentration of urine by stimulating reabsorption of water from the distal renal tubules of the kidneys. So it works on the distal renal tubules of the kidneys, okay? Stimulates reabsorption of water. When ADH is inadequate then, the tubules do not reabsorb water. So if they don't reabsorb the water, you get polyuria, increased urination. So manifestations, you're going to see polyuria, nocturia, enuresis in children. Okay, this comes on suddenly, this comes on abruptly. So what do you think we get this confused with, especially with the polydipsia? Diabetes mellitus. Dehydration is a hallmark sign of DI, but it also is of diabetes type 1. And this can occur at any age. In the infant, you're going to see irritability relieved by feeding of water, not milk. They want water, water, water. In the child, they have excessive thirst, 4 to 6 liters, and they void 4 to 10 liters, have bedwetting. In the adult, profound urinary output, 5 to 30 liters. They need a porta potty stuck to their bottom. And extreme thirst, 4 to 40 liters a day, and they want cold water to quench the thirst. Weight loss and weakness will occur. So what would you expect the specific gravity and the osmolarity of the urine to be, increased or decreased? Remember, their urine is extremely dilute, okay? So in the urine, you would expect it to be decreased. It is very dilute. But in the serum, it would be very increased because they're dehydrated. So in the urine, it would be decreased because it's very dilute. But in the serum, it would be increased because they're very dehydrated. Sodium is usually increased. They have hypertonic serum. As the patient's blood loses water, plasma osmolarity increases because of dehydration, because you've got more particles than solution. So how are we going to diagnose this? We're going to do the fluid deprivation test, okay, to make sure we don't have the other type of diabetes. This is the simplest test used to diagnose this condition. And what they're going to do is go in and restrict oral fluids up to 8 hours or until they lose 5% of their body weight and observe for the consequences, changes in urine volume and concentration. Now, during the restriction of oral fluids, you have to watch them because they get desperate. That thirst quenches there, and they have got to have something. They have been known to go in the bathroom and drink out the toilet bowls. They have been known to take out the plants out of vases and drink the water. Any source they can find, they will do during a deprivation test. In diabetes insipidus, restriction is not going to have little or no effect on urine formation. They're just going to keep on going, keep on going. But it does increase the dehydration. So you've got to watch them very closely during a fluid deprivation test. If it's positive, you want to give them a test dose of ADH. So you'll go in with about 5 units of vasopressin, ADH, and that should resolve your polyuria polydipsia because that's causing the whole problem. We don't have ADH down at the renal tubules to help with the reabsorption of water. If it doesn't help, let's say you go in and you give the 5 units of vasopressin and they keep going and going and going, then remember our 3 types was neurogenic, nephrogenic, and psychogenic. They probably got the nephrogenic type because they got a problem with their renal tubules, and no matter how much ADH I give them, it's not going to help. But you have to watch them very closely during a fluid deprivation test for vascular collapse. So they have to be monitored and weighed and checked daily. You want to assure adequate fluid replacement. I know daily weights and vital signs. Hormone replacement therapy is lifelong, and it may be required. Desmopressin, DDAVP, nasal spray is given. Oral or sub-Q is the drug of choice. Side effects include ulceration of the mucous membranes, allergies, chest tightness, and pulmonary inhalation. It lasts 8 to 20 hours, so it lasts for a while. How do I know if desmopressin's working? How do I know if my desmopressin, my DDAPH is working? Well, they should start not going to the bathroom as much. I should see a decrease in urine output, a decrease in thirst if the medication is actually working. You want to monitor weight because just a gain of 1 pound means about 500 ml of fluid has been retained, okay, during the medication treatment. If they develop a respiratory infection, that may interfere with absorption, so you want to report that to the physician. And major side effects, of course, if we're giving this for dehydration and prevention of it, but if we give too much, we can go the opposite direction and go into overhydration or water intoxication. So we have to be very careful that we're giving the right amount. Nursing considerations is early detection of the disorder. They have to wear medical alert bracelets. For the school-age child, unrestricted use of the lavatory and drinking fountains. Boy, that's an issue. And during illness, you need to increase fluids and medication. Now, SIADH, or Syndrome of Inappropriate Antidiuretic Hormone, is just the opposite. This results in excessive ADH secretion. So the causes can be central nervous system disorder, tumors is a big one, hypoxia stimulation, and some medications such as chemo can induce it. Now, ADH causes the kidneys to reabsorb water and fluid volume and decreases sodium levels. It is just the opposite of DI. So if you get diabetes insipidus down, SIADH is going to be just the opposite, because now we have overhydration that leads to dilution instead of dehydration. They don't void much, so urine, there's an increase in urine concentration in the kidneys because of the keeping it in. Manifestations, fluid retention, sodium levels greater than 120 or less than 120. Boy, I'm on a roll. Let's start all over. Manifestations, fluid retention, sodium levels less than 120, abdominal cramps, irritability, headache, personality changes, increased blood pressure, weight gain, and symptoms disappear when the underlying cause is actually corrected. Immediate management is restrict fluids and diuretics. Restrict their fluids and diuretics to about 500 to 800 ml per day. Signs and symptoms, if you think about low sodiums, would be stupor, coma, delayed tendon reflex, seizures. So you have to watch them. Okay. Nursing considerations is daily weights, I's and O's, monitoring their labs, watching them for signs of overload, seizure precautions, explaining fluid restrictions, which is not fun for anybody, support, and assessing their mental status. They need to report weight gain and loss. The sodium's low, so it's going to have to be replaced with hypotonic saline. And you just have to watch them very, very carefully. So diagnostic tests, their sodium levels would be low. Their serum osmolality would be decreased now because of the overhydration. They would have increased ADH levels. And they would have increased urine osmolality because now it is concentrated. So sodium levels would be low. Serum osmolality would be decreased because of the overhydration. Increased ADH levels. Increased urine osmolality because it's concentrated, as well as the specific gravity would be increased. Okay. This syndrome is generally managed by eliminating the cause and giving medication. When one venture ends, another begins. Next stop, adrenal glands. And again, I have posted for you some fast fact sheets. But if you have trouble with either one of those, the thyroid, parathyroid, or the adrenals, please let me know, and I'll be happy to get with you one-on-one. Thank you very much.